Well, first of all, hello, everybody, and thank you very much for inviting me. I'm an abdominal radiologist with expertise in MR and a lot of interest in the Free-Max. Sorry, my slides are not advancing. Okay, so the first question we ask ourselves, why low field? Why do we go back? Why don't we go up? An important consideration is cost containment or cost saving. A low field system is cheaper to purchase, cheaper to install, cheaper to run, cheaper to maintain, and cheaper to upgrade. So these are very important factors to consider when buying a scanner. And nationally, this is not just for the entire world, but even for us. There are two reasons. Nationally, we have to decrease the cost of healthcare. And even though imaging does not constitute more than 5% of the healthcare expenditure, what is happening is the individual studies or the individual tests, imaging tests, are getting more expensive, mostly because of the more expensive technology that we are creating, and that is an important factor in health cost, and healthcare cost has been increasing and will continue to increase. So cost containment on a national level is quite important. The other thing is also a low field system will make MR more widely available, nationally and internationally. Now, there are smaller healthcare systems, smaller hospitals that cannot afford to buy these big expensive magnets. So definitely having a lower cost magnet is much more beneficial and increases the availability of the modality, even in the United States. Of course, developing countries and other countries, this is going to be a major advantage to them. And we heard from earlier talks that there are many diseases that will benefit from early detection from MRI. Also, having a smaller magnet that is more manageable makes MR more available for regular use, not just to problem solve. And this is also, we heard about this together. So we're very excited when I came back to Michigan, which was a month ago, to see the Magneton Free-Max. And this was like my first thing was, okay, we're going to make this work. So this is a 0.55T commercially available magnet. It has a white bore, 80 centimeters bore, small footprint. It's relatively light. The height is not that much. And it utilizes a dry cool mechanism, which uses less than 1 liter of helium and no quench pipe. So that's quite important for cost containment as well. The maximum gradient amplitude is 18 and slew rate is 40. And that is relatively low compared to what we have on our standards 1.5 and 3Ts. And we have coils for abdominal imaging, which is what I'm going to talk about. For abdominal imaging, we use there's a bigger body coil and a smaller body coil. For abdominal imaging, we use two smaller body coils next to each other. Each one of them has 6 elements, and the spine coil in the back with 9 elements. The next question we ask ourselves, does it work? Does 0.55 work when now we want everything we do clinically done on the 3T? If we think about the progression or evolution of MRI, you realize very quickly that field strength is not the only factor that affects image quality. And if you look at earlier images from 1.5 Tesla and 3 Tesla scanners, they were of lower quality even on the same scanner. So this is an MRI, a T2 weighted image from an MRI of the liver in 2002 on a 1.5 Tesla. The same scanner, of course, a different patient. A 2022 liver MRI, T2 weighted image from a liver MRI looks very different. So clearly the advancement is not just the field strength, because it is actually the same scanner. So there were many advances over the year in gradient and coil technology, in acquisition reconstruction techniques, and all these factors help to improve image quality. So before applying the Free-Max or using it in patients, we went ahead and did a comparison of a few abdominal MRI scans at the 0.55 and the 1.5 to see what the images look like in healthy volunteers, and are we at a stage where we can use them in patients. So we had 4 healthy subjects scanned at both scanners, 0.55 and 1.5 Tesla. And we ran a set of standard non-contrast images we use for liver imaging, which is the breath hold, axial and coronal haze, the fat suppressed T2 weighted blade navigated, the axial T1 weighted dual echo flash, and then DWI at B50 and B800, and then a 3D MRCP, and MRCP stands for magnetic resonance cholangiopancreatography. These images were reviewed blindly by two radiologists who are fellowship trained in abdominal imaging. And the image quality was rated on a scale of 1 to 5, 1 being extremely poor, 5 excellent, for the following features. Number one, signal to noise ratio. And by that, I mean how grainy the images are. Image contrast, that is the ability to distinguish tissues of different signal intensity, for example, in the kidney, the corticomedullary differentiation, and also to the contour delineation was the other thing we looked at. That is to delineate the edges of the organs, for example, at the interface of the pancreas and the kidney, and the evaluation of the adrenal, and small structures like the pancreatic duct. And we looked also on MRCP, we looked for background suppression. So these are the 4 features that we looked at. We considered a score of equal or more than 4 to be acceptable from a standpoint of image quality. So if we start with the first set of sequences that we use a lot in abdominal imaging, T2 weighted imaging, you will see that all 3 T2 weighted images, the axial, the coronal haze, the fat suppressed axial T2 weighted sequence, the SNR was scored slightly lower on the 0.55 than the 1.5. Likewise, the contour delineation was scored slightly lower on the 0.55. Here are examples from the 0.55 and 1.5. So you can see the T2 weighted axial haze. This is a breath hold sequence. It's grainy. It has lower SNR, scored at 4 on the 0.5 and scored at 5 at the 1.5. This is a coronal T2 weighted haze. And we also said that the contour delineation was lower on the 0.5. On the 1.5, if you look in this area, you can see this line right here. That is the pancreatic duct that you see very well on the 1.5 T2 weighted coronal haze image, and you don't see that on the 0.5 image. And the score here was given a 3 to the 0.5 and 4 and 5 for the 1.5. Now, as a radiologist, we normally tend to live with these imperfections because we know when we don't see the ducts is that there is nothing wrong with it. But that should not be our scale when we quantitatively or qualitatively assess image quality. As for T1 weighted imaging, this SNR was very similar for the out of phase, only minimal less for the in phase according to the score, but the contour delineation was scored lower on the 0.5 compared to the 1.5. And here's an example of an in phase T1 weighted sequence. Lower SNR, slightly more grainy, hasn't affected the image quality, and better SNR, of course, on the 1.5 Tesla. For diffusion weighted imaging, the story is a little bit different. We have slightly higher SNR on the high B value image. And this is the image that we use for clinical diagnosis, mostly for detecting lesion, for characterizing lesions. There's higher score for higher SNR score than the 1.5. And also the contrast was considered to be better on the DWI images obtained at the 0.5. And contour delineation was also slightly better, you know, a surprising finding. So here's the B800 image from the liver on a 0.5 and on the 1.5. You can see on the 1.5, we don't see much. We have a lower signal in the region of the left lobe right here. And we don't see the edge, the contour of the left lobe, compared to better signal and better visualization of the contour of the left lobe on the 0.5. So on the 0.5, it was given a score of 5. On the 1.5, it was given a score of 4. MRCP had similar signal, but had much less background suppression, or less, slightly less, not much less, sorry, slightly less background suppression on the 0.5 compared to the 1.5 scanner. And here are the composite or the 3D MRCP images. Here you can see this is the bile duct, this is the pancreatic duct, right duct, left duct, same thing. Basically equal visualization of the bile ducts and pancreatic ducts, but you can see the background is noisier on the 0.55T compared to the 1.5T. But we noticed something very interesting on MRCPs. On the 0.5T, we were able to follow the ducts better higher up in the liver, which means as the ducts started branching and becoming smaller, we were able to see them better on the 0.55 than on the 1.5. So for example, here are the second order branches of the left duct, these two little dots. So these images are about 1.4 millimeter thick, and we stack them to produce the 3D image, the composite image that you just saw. But when we read, we look at these source images. So here are the images. You can see the second order branches left duct equally well on the 0.5 and 1.5. But if you go higher, you can actually see the third order branches better on the 0.55. Here are these little dots and this line compared to the 1.5. And that was true for all MRCP images. So MRCP, we were surprised, but it was a very nice feature that we use, and it's very useful for clinical practice. The other thing we suffered from on the 0.55 was the scan time. The scan time was longer. And if you just take the time on the sequences, it's 8 minutes versus almost 5 minutes for the 1.5. Now, really, in real life, it wasn't 8 minutes because of the T2 weighted sequence was navigated. So sometimes it took 11 minutes just to obtain the T2 weighted sequence. So the time was significantly higher on the 0.5 than the 1.5. So to conclude about our comparison, non-contrast liver MR studies performed on the 0.5 Tesla had acceptable image quality that was slightly lower than the 1.5 due to mostly lower SNR and more the T2 weighted images more than the other sequences. DWI was better on the 0.5, and that may relate to expected reduction in phase-related distortion artifacts at the lower field. And we were able to see smaller biliary branches on the 0.5 than on the 1.5, but we suffered from a longer scan time. What were the problems we faced in these volunteers? Low SNR. So that's related to both the low SNR of the scanner inherent to the 0.5 field strength and also fewer coils. That resulted in residual aliasing, which you can see here, and noise enhancement, especially when you had grappa reconstructions. Now, is the solution adding more averages? That prolongs your scan time and also results in breathing artifacts. And it does not resolve the problem of residual aliasing, which is related mostly to the fact that the coil had limited elements. So one thing we learned that we cannot use grappa or grappa factors or parallel imaging as high as we like. We have to use it judiciously. And also, for the time being, with the technology, we have to avoid situations where there is low SNR. For example, bigger patients, we don't tend to put them on the 0.55. And here you can see the noise in a large patient that felt very uncomfortable on the 1.5, but because of the size of the patient, the SNR was really very low and the study was considered non-diagnostic. So these were volunteers. What about clinical cases? Are we ready to do clinical cases? And we felt our image quality enables us to do clinical cases, and we started doing clinical cases. And specifically, we're doing liver imaging. So here's an example of a clinical case that was done to evaluate a liver lesion. And you can see there is lower SNR across all sequences, but the images are quite diagnostic and quite good. Again, these are the dynamic enhanced images, which we cannot do in volunteers. Again, you see there's a little bit of motion, but also you see that the SNR on the pre-contrast is worse than the post because the contrast increases your SNR. So if you see lower SNR on the pre-contrast, don't panic because that will be dealt with contrast. Another case with pathology. This is a patient with lots of liver metastasis from breast cancer. This is called pseudocirrhosis. And again, you can see the lesions very beautifully. Noisy images a little bit, but really the noise does not affect image quality. These are the dynamic imaging, which I consider them to be very beautiful, very diagnostic, and really nice images. Our third case, again, the same thing. The patient had a pancreatic lesion, and again, we ran the same standard protocol. And you can see, yes, the images are a little bit noisy, but very diagnostic. This is the MRCP. You can see the pancreatic lesion. And one of the questions we have in patients with small cystic pancreatic lesions is there enhancement or not? And for a lesion of this size to see whether there is enhancement or not, you need good quality images. And actually, I feel that I'm very comfortable to say that on these images that there is no enhancement within the cystic lesion within the pancreatic neck. So images are of very good quality. Of course, they're noisier than the 1.5, but that has not affected our diagnosis. So what problem did we face in this case? First of all, we had residual aliasing, which again, we said is due to lower SNR and mostly related to the coil. We had noise enhancement because of the low SNR that we have. But when we gave contrast, the problem slightly reduced. And you can see on the more delayed image, we've got very nice signal thanks to the contrast. Our fourth case is actually clinical case, was very interesting because it was a patient with a very interesting question clinically that was, is the pancreatic duct interrupted? And the pancreatic duct, as I showed you, is this thin hairline, thin structure that you barely see. So it's a difficult question. But actually, if you look at the images, you can see the pancreatic duct right here on the 0.5 beautifully. And you can see it is more dilated than usual. And again, these are T1 weighted images, the MRCP, they all look good. For some reason, the reader wasn't comfortable making that call on the 0.5 because maybe in their head, they thought the images are not good quality. So the patient was called back and the scan was repeated on the 3T. So we have a comparison in a real case, a difficult question between the 0.5 and between the 3T. And here you can see that the corona, it's noisier, of course, but the images are of extremely adequate quality on the 0.5 Tesla. And again, these are the diffusion weighted images, a post phase, in phase. Again, you see the difference in the signal, definitely more signal on the 3T, but it has not affected our ability to make a diagnosis. These are, again, the contrast enhanced images. The patient breathed during this scan, unfortunately. But again, we can see, we can answer the question what we need. And these are the MRCP images. This is the part of the duct that is abnormal. This is the part of the duct that is normal. And you clearly see it on the 0.5. I can say I see it better than on the 1.5, on the 3T that was done to verify the problem. And if you look at where the pathology was on the 0.5 versus the 3T, you see that there is no difference and you can make the diagnosis, even though the 3T image may be aesthetically more pleasing and it has less noise. So the question we have to ask ourselves is sit back and say, is a prettier image, does the prettier image translate to a better diagnosis? And that's something we have to seriously consider when we're reading these cases. And we have some historic data to help us. So if you look at per lesion sensitivity for detection of hepatocellular carcinoma in the liver on MRI, between 2005 and 2008, you will see that the sensitivity has not changed. It went from 81% to 82%, while between 2005 and 2018, we had so many advances in MR imaging. in terms of coils and gradients and reconstruction techniques and all sorts of, and parallel imaging. Yet the prettier images, the better images, of course, 3 Tesla as well, all these did not change the sensitivity of detection of HCC or hepatocellular carcinoma in the liver. So when we consider 0.5 and we think about it as a less better of a scan, we have to think that actually this may not translate into a difference in the diagnosis. And again, you see the differences between the the image that I showed you earlier in 2002 on a 1.5 Tesla scanner, and in 2022 on the same scanner, but with newer technologies. It's prettier, but it seems that it does not affect the diagnosis. So 0.55 is ready for clinical abdominal imaging, but we have to gradually test what's not working and optimize it. And we're doing that on a daily basis. And we're hoping to be able to put patients on it, like regular patients on it, but we have to test that we are able to see all sorts of pathology before going there. We are doing quite well. I mean, we're putting a lot of cases on it. And as I said, prettier images do not always translate to improved diagnosis, but you need, and it's important, you need images of diagnostic quality. It doesn't have to be prettier, it has to be of diagnostic quality. And you need currently we need continued optimization at the image acquisition and engineering level to ensure consistent diagnostic image quality for clinical use within acceptable scan times in order to make the 0.55 more widely usable. With this, I like to thank you all for your attention, and I'd like to thank the MIT team for doing all the work that I presented. Thank you very much. I'm happy to take any questions.